Okay, I don't want to say, Brett, are you able to hear us or can we hear? Oh, he's back. He's gone again. Okay, looks like Brett's in our backstage. Okay.
I'll go
Okay,
see if I can pull him in real quick. I'll be back.
awesome. Thank you. Okay, so I'm going to go ahead and get us started today, and then Brett will join us. So, welcome to our first of two webinars for the spring. This is Resilient Minds, Building the Capacity to Adapt and Grow. We are super excited to have you guys here with us today. Bethany will be our lead presenter, and then we also have Dr. Brett Ellis with us, and hopefully he is able to figure out his technology issues and get us and join us here in just a little bit. But until then, I'm happy to kind of stand in. Just some housekeeping things before we get started. This is a webinar style Zoom, so we will be the only ones that have audio and video capacity, but both the chat and the Q&A are also available. Brittany Talley, who was just in this room a minute ago, and she'll be back, is really awesome. She'll help kind of manage some of the administrative things. She'll help make sure that your questions make it to us if you are putting them into the chat and the Q&A. So utilize those two platforms to communicate as much as possible. Additionally, for the CEU certificates, upon the ending of this webinar, you should automatically be prompted to fill out a survey. If that doesn't happen, the link to the survey will also be in the chat. It will also be available in the lobby of this webinar until 2 p.m. today. And then if all else fails, you're more than welcome to email Brittany Talley for that survey link. Once that survey is completed, your CEU certificate will be automatically sent to you. And Brittany Talley will make sure her email is in the chat as well. The other way to contact us if needed would be to utilize the Canberra website. That will make sure that one of us gets your email and we'll try to get you the resources that you need. We will have the slides will go out with the recording post webinar. And so you should all be able to receive those after this. So you'll have all the information that we're talking about today. I'm trying to think if there's anything else from a housekeeping perspective that I'm missing, but I think that's about everything. So Bethany, I will hand it over to you and you can introduce yourself.
All right. Well, hi guys. Welcome. Thank you for being able to join us today. I look forward to sharing this material with you. So my name is Bethany Nold, and I'm a licensed clinical practicing counselor. I am the program development coordinator at Canberra Mental Health. Prior to that, I was a clinician for 8 years at our Kansas City location and did 2 years in our aftercare and reintegration services for the KBC side. So I'm a clinician at heart, but for my purposes at Canberra, I oversee the development, advancement, and implementation of our resilience programming. And that kind of gives me some a leg up to talk to you about some of the things that we're going to share with you today.
Awesome. And it looks like we have Brett. Brett, are you good?
I,
Are you
I,
here?
I'm here. I've got Zoom working on my phone, not the computer, but I'm with you. So I'm excited
Awesome.
to be with you.
Well, I'll let you introduce
So,
yourself then.
yeah. So my name's Dr. Brett Ellis. I am the Vice President of Community Engagement and Leadership Development for Camber and KBC, Missouri. I'm one of the newbies, so I've been with us for right over 3 months, and just loving my time serving alongside servant leaders. I spent almost 30 years in the fire service and working my way as a first responder, a firefighter, paramedic, all the way to fire chief. And I can tell you, courses like this really connect deeply to what I would have needed to have this resilience conversation growing up in the fire service. So I'm extra excited to spend this time with you, especially with Bethany, our subject matter expert, as I get to learn from her and I get to spend time with you, having a very proactive conversation about resilience. So thanks for having me.
We're glad you're with us, Brett. So let's talk about what you're going to learn during this presentation. We're going to talk about what resilience is in children, what it actually is, and what it isn't. We're going to talk about adaptability and emotional recovery and how that shows up in youth behavior. We're going to talk about why it's sometimes difficult to adapt and how this is a skill-based challenge, not necessarily a behavioral problem. We're going to examine ways caregivers and educators can better understand and support resilience. And we're going to touch on how consistency helps youth recover, re-engage, and grow. So when I like to share things about resilience, I like to start from the beginning. So believe it or not, the concept of resilience has actually been around for a pretty long time. It started in the mental hygiene unit in the early 1900s during World War II. And this was the first time that we really saw people start to link mental health and prevention to the environment. And so a movement was created which sought to reform what was back then asylums and understand how like community and environment shape emotional well-being. So like previously, we considered when we during this time we considered like psychological and emotional struggles to be what they called maladjustments. So these were like barriers to healthy development. And this was pretty big because prior to this, we functioned in the mental health system as though once people were ill, they couldn't get better. So we treated anything emotional, psychological, psychiatric in nature as a terminal illness. So this was a pretty big step. And this was when experts started to see how these issues stemmed from like deep, often unconscious behaviors. And we started to process the fact that willpower alone couldn't get us through things. And so this is when we started to examine resilience not from the perspective of just telling people to get over it, but understanding like if they were to get over it, what does that actually mean? What is it that we're trying to get over and grow from? And so obviously this wasn't perfect, but this was like our first glimpse of this. And so we started looking at prevention and education and I know Brett really likes this quote by Dr. Walter Brandon Langdon Brown. Sorry, oh my gosh. So I'll let Brett kind of share his connection to that quote and how this all ties together.
Yeah, Bethany, thanks. So I do love this quote by Dr. Walter Langdon Brown. It says, "The will cannot control what it does not understand." I found this to be such a rich, deep wisdom moment, where we must never stop learning as learning leaders and never settle for status quo. And so I connected with this, where it was really about staying hungry for knowledge by asking questions and seeking those transparent truths. I thought about curiosity, especially with those forefathers who really started to move resilience to the forefront. That curiosity, and they started asking those questions. That it coupled with courage and conviction leads us toward those transparent truths. And although early practices were imperfect and sometimes harmful by today's standards, the movement laid the groundwork for modern resilience research by recognizing that mental health begins in early childhood and is shaped by environment, relationships, and support. And this is key to our DNA at Camber and KBC and how we care for people. Environment, relationships, and support all through connection.
Absolutely. And now we have modern resilience, which is growing through adversity as opposed to getting over it or stepping over it, right? So let's talk about resilience models.
Yeah, I love these models. And one of the cool things is that there are multiple models of resilience, but they all have a common, and what they have in common is they include emotional regulation, body regulation, a social component, and an executive functioning component. So they pull all these together, and specifically, you know, the seven C's of resilience for me is what I connected to. Uh, and this is, I love alliteration. So in addition to that, to go through as a visual learner, the seven C's of competence, the ability to handle a situation effectively. We obviously can help increase competencies in our roles and as we serve children and serve adults. But clearly, confidence is critical in that, believing in our own personal abilities, which self-efficacy, which we'll talk about later, has a connection there. And speaking of connection, creating a sense of belonging. This is literally what we, from Maslow's hierarchy of needs to we all need connection for our catchphrase and motto for Camber and KBC. Because connection is that sense of belonging. Character, having a solid set of morals and values. And I love how our values as pour into our people who pour into our children as we try to live those values and mission out every day, that the heart of our work is helping people. And then our contribution, ability to make a difference. I have no doubt that everyone on this webinar is contributing their own skills and passions to making a difference in people's lives. Also, being able to handle stress appropriately through proper coping mechanisms. I'll share a story later on, my own part of my testimony as a first responder of how important coping mechanisms with potential symptomatic responses for trauma impacted me. And then control, knowledge and ability to affect an outcome. This is by Dr. Ken Ginsberg, often used with children and youth. And so I think what's key is that for these seven C's of resilience, one, I find it easy to remember, but also previously, resilience was seen as one's ability to overcome hardships. And that view didn't always account for long-term effects of trauma or social supports in family or school environments, or even cultural and systemic influences. I love that modern resilience research, it's more of a process. This even helped change me from understanding that it's not just bouncing back from adversity or challenge or trauma or traumatic experiences, but it's a process to embrace a growth opportunities of growth. And it's something that's shaped by relationships, by resources, and by context. And I know, Bethany, you're going to touch on domains of resilience.
Yeah, so we reviewed multiple models of resilience when we were researching this presentation, and I did include the domains of resilience. It is the most common framework when it comes to like trauma-informed care, which is something that we really operate under at Camber. It's one of the pillars of our functioning and the services we provide. And I also cited the APA's domains of resilience, and that's more of like that biopsychosocial assessment, right? And so all of these different domains cite, various things, but at the heart of it, there's an emotional component, there's a cognitive component, there's a relational component, there's a physical component, and meaning making and self-efficacy. And that's something we're going to talk a lot more about in future slides. So just to kind of give you a snapshot of some of what we found to be the most relevant resilience models before we kind of get into what we're going to present on today. So let's talk about low resilience. In order to talk about how resilience affects behavior, we got to talk about it at its worst and at its best. So low resilience for our purposes is difficulty managing emotions that can lead to impulsivity, aggression, trauma, low self-worth, learned helplessness. And so when we have low resilience, we are more sensitive to these situations, and it makes it harder for us to bounce back, to rebound, to grow through, to be able to process things. We get really stuck in those adverse emotions. And this really intensifies the cycle of risk, and this creates the cycles of like poor coping. And that fuels conflict. And so one of the most common ways that we see conflict in our society is through violence. Physical violence, intended to hurt, damage, or cause harm. A lot of us that work with youth talk a lot about school violence. So that's violence that occurs in the school setting. And unfortunately, low symptoms of low resilience really results in this cyclical pattern. And because of how serious this can escalate, sometimes it makes it harder for us to step back and look at how this started or where it came from because we're so focused on mitigating the immediate safety risk.
Well, the signs of resilience, dysfunction in multiple settings, and we have another slide later on. We're going to even dive deeper into these. But these are those four areas that really we should dive into, not just for ourselves, but how we pour into others and how we provide that for people. And so number one is interpersonal safety dysfunction. Uh, Absolutely key, and we're going to circle back to this in the very end, where social exclusion or isolation across settings can occur. Verbal aggression dismissed as joking, poor conflict resolution, escalating disputes, fear of anxiety due to bullying or threats, harassment or exclusion that erode trust, and avoidant or unsafe coping behaviors. If we don't feel safe, if a person doesn't feel safe, now it impacts our body regulation and dysfunction, where there's restlessness or fidgeting in different environments, outburst or physical agitation when we're upset, difficulty staying still or maintaining a comfortable posture, strong reactions to touch or noise or other sensory input, fatigue, withdrawal, or even shutting down after sensory overload. Our body is compensating and trying to figure out fight, flight, fawn, or freeze. And where are we in this because we don't feel safe, and from emotional safety or physical safety or mental safety. Emotional regulation dysfunction, mood swings or sudden crying across settings, anger over minor frustrations, shutting down when upset, difficulty calming after conflict or feedback, or overreacting to disappointment or correction. And then our executive functioning dysfunction, the disorganization across settings, difficulty starting or finishing tasks, impulsivity and poor self-regulation, forgetfulness with instructions or materials, and even emotional overreactions due to stress. As we circle back to interpersonal safety dysfunction, especially that second bullet, the verbal aggression dismissed as joking, one thing that really stands out to me is this concept of verbal aggression that's normalized as jokes. This is a classic behavior that we see in kids. And when dysfunctional behavior is normalized, it makes it harder for youth to speak up about things and question their own responses to things from an emotional lens. And so the normal, the way that words are used, especially through communication, the way it's normalized that aggressive jokes, specifically amongst teens, are deemed just normal. This is can be very problematic because words matter. No matter what age we are, from kids to adults, words matter. Aggressive jokes, when normalized, can be extremely traumatic. And so all four of these areas increase risk for a psychiatric crisis when unsupported. And so a goal or a challenge for us, and how we pour into our folks and our kids, is to normalize kindness through words and actions while creating an environment where connection is authentic and relational support fuels that connection.
Absolutely. Let's take a further glance into how the impact of low resilience looks like on behavior, especially when it comes to predicting violence. So we know that people with low resilience
Hey, Bethany.
are, oh, go ahead. Yeah.
You're fine. I just noticed a question that I think is a really good one in the chat.
Yeah.
I'm just gonna ask it. Someone is asking or kind of made the observation that the signs of resilience dysfunction look really similar to ADHD symptoms. Can you kind of talk about the similarities and differences there and how they kind of differ or relate?
Yeah, absolutely. So this is very similar to ADHD. This is pretty similar. I mean, there's a lot of comorbidities across multiple conditions, depression, anxiety. And I think these conditions, it is probably pretty safe to say that having ADHD might make you more vulnerable to difficulty managing these specific areas. I could say the same for, depression or anxiety. There's a lot of like poor body regulation with anxiety or depression, mood swings or having a hard time when you're upset or having like poor distress tolerance, right? Like all of these things definitely link to mental health. It's like we can't definitively say that if you have like a pre-existing condition, you will automatically struggle in this, but these conditions are symptoms of poor resilience, right? So one doesn't necessarily equate the other, but there is definitely a lot of connection. I don't know if that kind of answers the question.
Yeah, I think that's great. I think that it's just like you said, important to point out that it that having a breakdown in resilience skills or the way that low resilience may look is going to be really similar or could be, an area of increased focus for different disorders.
Yeah, especially with executive functioning. We all know somebody that is a recovering kid that put their papers in their backpack. That was me, right? So if we look at executive functioning, difficulty having, with organization, put my papers in my backpack instead of my folder, and then eventually I quit bringing a backpack. So yeah, we can definitely tie these all in to mental health conditions with pretty comorbid symptom presentations.
Thanks, Bethany.
Yeah, so when we're talking about like low resilience is tied as a prediction of violence, right? So for victimization, people who are at risk of being victimized by low resilience driven behavior and violence are often people that struggle in peer and social relationships. They lack social competence. They may be perceived as being aggressive or unpredictable at school, and that's often like a poor emotion regulation. And so we see kids in our, patients in our facilities every day who had an episode at school that could have been, could have felt very aggressive or violent or unpredictable, and that's, that poor emotion regulation. On the flip side, people that perpetrate violence also are at high risk of having low resilience. And so those are our delinquent behaviors. Delinquency is just like lack of regard for like the law, right? Or the rules. The antisocial behavior where we do things without thinking about how they impact other people, or there's just a general disinterest in other people's well-being. We see ADHD in this category again, because of those symptoms that put us at risk of low resilience in some areas. It makes it harder. Kids who experience abuse, mistreatment, kids who experience rejection by their peers, they may have a moral disengagement, which just means that they don't necessarily agree with like basic morals that we kind of all agree on, right? Like we don't hurt people, we don't hurt animals, we don't hurt other people, we don't take things from other people. There can be deviancy, which again is more of like that harmful criminal behavior. People that experience narcissism or exposed to it, also exposure to domestic violence. So those things make you at risk of perpetrating violent behavior and having lower resilience. And then we have the blue box. And that is like what is those commonalities or those things that we see on both sides, right? And so people that fall into either of these categories can have a hard time making friends. They can have a hard time learning or concentrating or completing work. They can have lower grades, issues getting to school, staying at school, in the form of absences, suspensions, expulsions, things of that nature. And so it's just important to remember that these things can be one and the same, right? So somebody that's experiencing this also has a lot in common with somebody that's perpetrating this behavior. And it's because all roads lead back to resilience and the additional psychological stress that somebody may be experiencing that makes them more at risk to not handle things the best or cope the best or make safe decisions. Oh, whoa. Oh, sorry, guys. I froze and then I clicked too much.
Yeah,
Right.
so
There's Brett.
understanding vulnerability and temperament within resilience. And I'd like to start off with this graphic. Gosh, I love this graphic so much as a career first responder, as a paramedic, as a firefighter, as an incident commander on large scale incidents to identify one that in that life, it seems like it was already forever ago. We were all risk managing problem solvers, where we showed up to fix everybody else's problem best we can, what we got. And so identifying just in that graphic that as we identify the hazard and the frequency and the intensity of a hazard and how it takes both, which we'll talk about vulnerability in detail here in a second, courage and vulnerability. And in that process, we're still exposed to the sensitivities and the impact of being vulnerable within that incident, all pointing back to the goal is to lessen, to eliminate risk, but we know that's not always possible. And so this graphic is very helpful to see that. And when I did my own original research for my doctoral dissertation in defense years ago, I focused on firefighter suicide ideation in relation to traumatic events. And one of the things just identified, and this can translate into multiple worlds where we help people, especially based on trauma, or what could be deemed traumatic experience because it's so subjective, is that frequency and incident type and is a huge contributing factor to somebody who could exhibit symptomatic responses, especially with recall. So if we had a 3-year-old unconscious call, and it could take one call that impacts somebody, or it could take multiple calls based on patterns, frequency, that could impact somebody in a negative way, therefore increasing their risk for suicide ideation or contemplation. And so I share that as a transition of talking about vulnerability, because vulnerability and courage are synonymous. And although there's no one definition, because it's a very complex and context dependent, I turn to the amazing, great Dr. Brene Brown, because Dr. Brene Brown spent over 10 years just researching vulnerability. And so she defines vulnerability as uncertainty, risk, and emotional exposure, emphasizing that it is not weakness, but the clearest measure of courage. And so I look at vulnerability and courage as synonymous, as a couple walking on the beach hand in hand. You can't have one without the other. Vulnerability, though, is not a weakness. It's our most accurate measure of courage. And so when the barrier is our belief about vulnerability, the question becomes, are we willing to show up and be seen when we can't control the outcome? But when the barrier of vulnerability is about safety, which connects to one of our 4 core, the question becomes, are we willing to create a courageous space so we can be fully seen? And so for vulnerability, this connects so much to resilience, specifically our mission at Camber and KBC to create these courageous spaces where our staff and children can be fully seen through intentional connection, as the heart of our work is helping people.
And so it's important that when we talk about vulnerability, we talk about temperament. And so as a clinician, I experience a lot of feedback when it comes to temperament. And so it's important to understand that temperament is your natural style of reacting to the world. It's how easily you get upset. It's how active or calm you are. It's how you approach new situations. It's your default settings for emotions and energy and behavior. And that's what you're born with, even before you learn from experience. And so people that, work in a clinical capacity, are confronted with the concept of temperament. And so I've had clients over the years present with some pretty tough temperament and presentation. And I've had caregivers, guardians, support individuals, say they need to work on this in therapy, and we can't pathologize away your temperament. We can't make you be less sensitive. We can't make things impact you less. We can teach you skills to manage it, but temperament is not necessarily something that we can, make go away. And so we know that temperament and vulnerability really go hand in hand. And so they are intricately connected, and traits such as like high reactivity or low regulation can increase vulnerability to stress and mental health challenges, while on the flip side, positive traits and nurturing environments and strong social skills can serve as protective factors. However, what we are willing to take in varies based on the person and their vulnerability. And this is, in true practice, this looks like using a very tailored intervention that in theory should check all the boxes for one specific client and doesn't even touch them. And I know anybody that's, been an educator or clinician or served a specific at-risk population knows what I'm talking about. Our outlier friends that just don't seem to click or respond to the interventions that seem to work for most people in this situation. And so it's important to know that resilience or our susceptibility appears from how often we enact with these traits in your environment. And so to go talk about that further, we're going to talk about the diathesis stress model. So that's a whole lot of words, right? The diathesis stress model explains that mental health problems can develop when a person's underlying vulnerability combines with stress. And when we talk about vulnerability, we're talking about genetics, personality, temperament, or early experiences. So when people may have, things that might be a hidden weakness or a growth point or pain point, or vulnerabilities to certain types of situations, that's the diathesis. And when the stress becomes significant, and that can look like trauma, illness, or major challenges, someone with these vulnerabilities is more likely to develop anxiety, depression, or other difficulties. Without vulnerability, or when stress is lower, problems are less likely to occur. But we know as adults that stress is unavoidable, it is innate, and it's also healthy. Stress keeps us on our toes, keeps us going. And so I like this model because it really influences how much we understand and influence and develop from a stress standpoint, right? So, but this doesn't account for resilience. So again, for the people that may not fit into one box or one category or respond to one specific emotion, it's important to remember resilience is innate and individual. And so we can have this model that kind of gives us a snapshot, but there are other theories involved that can, explain some of those outlier situations better. And so that's where the concept of vantage sensitivity comes in. And when I was researching for this presentation, I came upon the theory of vantage sensitivity, which is just that. It's a theory, and it didn't directly evolve from the diathesis stress model, but it emerged in response to its limitations. And the limitations are resilience and why some things are more difficult than others. And so vantage sensitivity is a theory that we're going to explore. And so the best way that I can think of to explain this to you
Hey,
is
Bethany.
to look at, oh yeah,
Oh, well, there was a question,
yeah,
and you might get to it, but I wanted to ask before you jump into this. Someone was saying, how
yeah.
does epigenetics and longitudinal trauma impact temperament and the ability to mitigate and alter reactions?
So that's a really great question. And that, epigenetics, that's, the things that the trials and tribulations that we inherit through our family bloodline, right? And so I would say that it definitely impacts it. Um, and it's going to be very similar to like when we talk about vulnerability, which is that, you may have these longitudinal family traumas and risks of epigenetics and, inherited things that, run in your family, especially for like certain minority populations. And um, I would say it definitely plays a role. I can't tell you how it impacts it because for some people, they are going to not be as vulnerable. And so they may have these vulnerabilities, but maybe they are more resilient. The innate skills that they started out with help them get through that. And others may be more at risk. Um, and so can I tell you it absolutely affects it 100%. To what degree, I don't know, because it's a really hard thing to measure because we go back to the fact that like two people who come from the same family history, same, environmental experiences may still turn out to be very different people. And so there's no way to predict how this is going to present in someone. I don't know if that answers the question.
I think you did a great job. And someone also followed up saying, like, why do you think some people are more resilient than others to trauma? And I feel like you answered that just a little bit, but wanted to give you a chance if you wanted to add anything about that.
So I think it goes back to like sensitivity. And that's kind of what I talk about a little bit on this slide. Some people are more resilient because they may innately not be as sensitive to certain things, or they may be more sensitive to things that work in their favor, right? And so for the for the situation with this case study, if we look at this on the whole, we have a person, Marie, who is 15. That's a really tough age. Lots of domestic violence, emotional neglect in the home. And as a result, we see how she presents quiet, cautious, very emotionally sensitive. And she tends to withdraw in unfamiliar situations and struggle to trust adults. All very valid, all 100% a result of those experiences, right? But when we give Marie access to our best cure, right? Our best set of interventions. We've got a supportive teacher who's seeing when she may be over emotionally responding to things, or maybe more impacted by a story or something you're studying in class. And this person responds to her and tends to her. She starts to feel safe. And then over time, she wants to participate in more because this teacher has made her feel safe. And then she sees like, oh, that's a caring adult. I can probably trust other adults, right? And it kind of grows from there. And this matters because her early traumas heightened her emotional sensitivity. So because she was more sensitive, she was vulnerable in unsafe environments because she struggled to be regulated, and she was essentially learning, like she didn't necessarily learn what a safe and unsafe environment was. So even when she was in a safe environment, she was reacting as if she wasn't in a safe one. So a little TLC, a little consistency that helped her feel connected, and we saw improvement. And so that's strong, like that's vantage sensitivity. So that's this theory that some people respond better to interventions and are more sensitive to things than others. So, Marie also, though, if you look at it on the whole, had all the ingredients to be very mistrustful and mistrusting and resistant to adults trying to help. But she didn't, right? And so we've all had that client that responded well to the TLC and what the doctor ordered from a therapeutic standpoint, right? So if we look at this other scenario, we look at Jason. boy, 16. He's been in foster care a lot, moved around. He's experienced instability, neglect, and betrayal. Betrayal is when our caregivers don't show up for us. They choose other things over us, make us feel like we're not a priority. And over time, he learned not to trust others and keep his emotions guarded. So, very similar to Marie, he had the foundation to have no reason to believe or trust that other people could be good or safe. And so then, typical what the doctor ordered intervention style, he's placed in an alternative classroom with wraparound services. So we're going to throw a blanket over him and hold him and hug him and do all the things to try to make him feel good, make him feel safe, counseling, mentoring, academic support. And he still struggles to engage. Other students in his classroom that are very similar begin to build relationships and use their resources and make progress. He doesn't take the bait. He stays distant and withdrawn. He avoids connection, still being very disengaged despite being in a supportive environment. And that's what we see as people that in a helper profession, right? For every one or two Maries, there's like 5 or 6 Jasons where we just can't seem to figure out why everything that on paper looks like it should be helpful isn't. And this matters because those early traumas led to an emotional shutdown. A deep mistrust makes it difficult for him to receive help, even in highly supportive settings. And so he is what we would consider somebody with low vantage sensitivity. So his adverse experiences made him less receptive to positive experiences and relationships. And this really highlights the need for patience and consistency and long-term trust-building interventions, because it's hard. When you're literally doing everything, why is he not sensitive to good feelings? Well, it's because he had early experiences that kind of trained him to not have good responses to good feelings. So feeling supported, cared for, nurturing, people checking in on him feels gross. It doesn't feel good. It doesn't, cause the same reaction that we saw in the other case study. And so as we talk about this further, I like to introduce the concept of learned helplessness. If you've ever worked in a case management capacity, you've met this client. And I like this video because I feel like this guy explains it really well.
What is learned helplessness? Learned helplessness is Learned helplessness. Learned helplessness is a psychological state where a person comes to believe that they have no control over their situation, even when opportunities to change it exist. So, because of past experiences where nothing they did seemed to make a difference, they stopped trying altogether. So they were actually helpless earlier in life. That then results in them gradually beginning to think they're always helpless. So let me give you some examples. Many of you may know somebody that's in an abusive relationship and they don't leave the relationship, and you quiz them on that. Why aren't you leaving? And it's they feel helpless to live the relationship to improve their life. They stay in an abusive relationship, even though there's options to leave it. They just feel helpless to take those options. No matter what you ask them to do, they always come up with an excuse for why they can't do it. So they act like they're willing to do it, they want to do it, but there's always an excuse why they can't do it. Or you have a family member who refuses to do something if it involves hard work, learning new skills, or possible failure. So hard work, new skills, possible failure, too scary, too difficult. No, can't do it. So they settle for the status quo, staying where they're at. You can ask them to do a job and repeatedly they say, no, I can't. I don't know how. Can you do it for me? And the reality is they've never tried to learn. They've never tried to get the skills. So that it's always this, I can't do it, I don't know how, but they never try to learn how. You want them to use a smartphone or a computer? No, I'm too old. I can't learn. It's just too hard. And so they again stop, refuse to learn anything, to put themselves out there to try to gain skills. So what I hope you're seeing is that this often shows up in kind of relationship issues, especially abusive relationships, where a person is, they know it's abusive, but they feel trapped. They don't feel they can get help. They don't feel they can leave. They feel they don't deserve something more than that. And so they stay stuck in this very unhealthy situation.
So I think, like I said, we've all had this client. When I worked with parents with addiction issues, I saw this a lot, right? And the symptoms of learned helplessness are passivity, which is like the inaction, even when opportunities appear. So even when things happen or things become available to help you make a change, there's no activity. Low motivation. So just the, lack of desire to interact or initiate things. Low self-esteem. And I think that is really at the core of learned helplessness, this persistent belief that we are inept, that we're just not going to get it. And so why try? This also shines through in cognitive issues. So the poor problem solving, making decisions, and emotional numbness. So apathy, if, something bad might happen, it might not. I don't care either way. And so while this isn't necessarily like a condition, it's more of a theory, but it's often viewed through the lens of attribution. So how people explain their failures, whether it's personal, universal, or global, and it is caused by like chronic, uncontrollable, and traumatic experiences in personal or professional or educational settings. So this doesn't happen overnight. And to use a word that Brett has used during this presentation, these persistent exposures to adverse experiences takes away your courage and makes you defeated and makes you feel stuck. And then it's essentially though you've learned to be helpless because you have no motivation to try to improve, but you also may have tried and not been successful. And so that's really reiterated to you the best way to be is the way you are, which is stuck.
That's a great transition, Bethany, into self-efficacy and resilience. As we dive into self-efficacy, defined as refers to an individual's belief in their capacity to organize and execute actions required to attain specific goals. And in a research study that was conducted, it found that self-efficacy does not directly improve mental health on its own. Instead, it works indirectly. Higher self-efficacy leads to stronger coping and recovery, to improved resilience. Low self-efficacy leads to barriers to recovery, to decreased resilience. That resilience is that bridge between self-efficacy and mental health. So self-efficacy, originating from Albert Bandura's social cognitive theory, encompasses the cognitive appraisal of one's capabilities, incorporating experiences, social modeling, and feedback as determinants. Bandura suggests that self-efficacy operates as a central mechanism influencing human agency and behavior, shaping the cognitive and emotional processes essential for goal attainment. So in relation to mental health, growth becomes not just possible, but probable. If we can predict it, we can prevent it. And so an example I would share that was very personal was during my doctoral research journey. I had lost a friend, a firefighter friend, to suicide. And after speaking at Jason's service, I thought, well, this sucks. I don't want to do this again. And so I've got to do something about it. So I dove deep into the impact of traumatic events on first responders. And so when I started this process, I actually didn't know what I was getting into. And as I was discovering through the courageous sample group that I had that shared some of their deepest traumas and coping mechanisms and symptomatic responses that others would see, some self-awareness grew in myself, and I was able to better identify healthy coping mechanisms and based on certain traumatic triggers, knowing that what symptomatic responses could others could see, even in myself. So I was able to process some of that, where identifying that individual resilience, that internal locus of control, in addition to occupational resilience, that experience over time, with those healthy external locus of control, support systems and mediums really helped me personally, professionally, as well as the people that I got to pour into and speak around the country on this topic, when it came that those support mediums are so critical, that was external supports, because we can't do it all on our own. And so some improved resilience occurred, not just contextually bound to a first responder's life, but just in general. And so I really appreciate, regardless of context, that self-efficacy, even that in that goal setting, which sounds so formal, but if a goal for me was identify a trigger, therefore know how to respond and react, having processed some of those traumas, that through resilience, through that process of embracing a growth opportunity, not just bouncing back from trauma or adversity, that therefore improved my own mental health. And so I share that testimony, 100% being all in with what we're talking about today, and the how critical resilience is for both internal resilience, individual, as well as that external support.
Yeah, absolutely. So when we look at this, with regard to the youth that we're serving, is it a lack of skills or is it a behavior problem? And those of us who work with kids know that that's a question that we are asked every day. And it's important to know kids do not inherently lack resilience necessarily. Their ability to bounce through is simply structured differently because of the developmental and biological influences like brain maturation, hormone changes, and life experience. And so we have all seen this, kids at a certain age having a set of skills, and then as they go through another developmental season in their life, or maybe become a teenager, teenagers are very good at having learned helplessness, right? We may see a regression. And so it's not that they don't have that resilience. It's that it's different. And as it's going to change as they develop. Children and teens are still developing brain systems that make it possible. So while we're born with some of this, it's an ongoing learning curve. The prefrontal cortex is the area responsible for planning and impulse control and emotional regulation. And we know it keeps maturing well into your mid-20s. And as a result, young people tend to rely more on, those emotional reactions or limbic reactions rather than logical problem solving under stress. I'm sure all of us have a reminder of something we did before our brain was done. It could be in the form of credit card debt, a tattoo, who knows? But we know we're not done in our development until our mid-20s. And then we have to maintain and continue to learn, and it becomes another phase. And so while this may seem like kids are more reactive than resilient, it's important to remember they are still building the tools, skills, and capacities needed for resilience. And so it's important to keep in mind that this is shaped by practice and exposure. So it's a practice. It's going to take time. And then when we factor in that a child is exposed to toxic stress, the areas of the brain, toxic stress, illness, trauma, all those things fall under toxic stress. The areas of the brain responsible for these tools are affected, right? And then that's where we kind of have that side quest type of situation happening. So when we talk about practice means sitting back and looking at how the child is presenting and seeing where that is in resilience. So what does that behavior align with in terms of a resilience area they may be having a hard time with? And going at it from that perspective, trying to focus on the root of the behavior when able. So this next slide I'm going to share is a really great video that kind of shows you how systematically toxic stress and all these other factors pile up when it comes to brain development.
If we're going to cross the street and a truck is coming at us, we have release of adrenaline. We have release.
It started too early. There we go.
The reality is that we all need a certain amount of stress, a certain amount of anxiety to perform well. We don't care about that exam that we're going to have tomorrow. We'll probably fail. If we're going to cross the street and a truck is coming at us, we have release of adrenaline. We have release of a hormone that we call cortisol. We want to jump out of there, and adrenaline and cortisol are going to help us. So there's that good amount of stress. But if all day long you're feeling like a truck is coming at you, day after day after day, that's going to take a toll on the body. And the amygdala, obviously, here has greater activation.
Yes.
In the PT. We were able to image children that had experienced trauma and compare those brain images with children that didn't have an experience of trauma, didn't have symptoms.
Right. An exaggerated fear response.
An exaggerated fear response with decreased activation in areas that we need to control that emotion in the frontal areas.
Exposure to early adversity and trauma literally affects the structure and function of children's developing brains. The kid next to them hits them, or the teacher reprimands them in a way that they're uncomfortable with, right? Literally what they're feeling, that activation is like there was a truck coming at them. You can give something that will mask symptoms, right? For example, if someone has a cough, right, you can give them a really strong cough serum that will suppress their cough. But if it's because they have tuberculosis or lung cancer, then what you're doing is merely masking the symptoms while the disease process continues to fester. We know what's happening in children's brains and bodies with the experience of toxic stress. So the question now is, what do we do about it?
So I like this video for a lot of reasons. Like I said, it's a really good example of what we're talking about. And it also points out the fact that stress is necessary to functioning. And so stress is a balance. It's a balancing act. We have to have stress because that's our get up and go. That makes us motivated, makes us work harder, but also it can become toxic. And so it's really, it's a balancing act. So when we talk about balancing act, I'd like to introduce the resilience scale that we use here at Camber. And so this is really the corner. This is our foundation. And so our resilience scale encompasses these 4 domains, right? Executive thinking, emotion regulation, body regulation, and interpersonal safety. And so this resilience scale is a simple way to explain how children grow and adapt. And it also helps people understand big ideas. And so we at Camber, many moons ago, before I worked here, this scale was adapted from the Frameworks Institute. And it was the Frameworks Institute's goal, in partnership with Harvard Center on Developing Child, was part of a bigger effort to make early childhood science easier for the public to understand. So trying to break things down and simplify it so that everyone can understand them. So it's very similar to the mental hygiene movement that we talked about at the beginning of the presentation in the early 1900s, where they were trying to really break things down and process them. And so tools like this make it easier to understand brain development and stress and caregiver relationships and why they matter. And so one of the key things that came out of this research was the resilience scale. So just being able to have this visual of if we have all these skills on one side and then we put the other things that cause the balancing act on the other, being mindful of what we're doing and building and adding to help balance it. Because we know that some of the things on this left side of the scale are not avoidable. And some stress is necessary.
Well, Bethany, go back a few slides ago. Thanks for validating that my frontal cortex was not developed fully at 19 when I decided to briskly go into burning buildings and do CPR on people constantly. But it just feels so validating to be with you. So thank you for that. I did have a little bit of a switch in my mid-20s. I felt that there were some things that started to make a little more sense and not so impulsive. So yeah, I love getting to do this with you. On this slide, kind of an extension of our previous one that shows kind of the weighted seesaw back and forth is Camber's resilience domains. And so at Camber in our joint ventures, to touch on what Bethany was sharing in these four key areas, it is really is the foundation of training for our staff and our clinicians. And the same framework also guides our programming in our milieu spaces, where our folks are serving and walking alongside our kids each and every day. And so here's what we do know. The interpersonal safety, that when someone doesn't feel safe or supported in relationships, this is a detriment to how they could perceive resilience. Isolation and distrust and lack of connection, critical components with that interpersonal safety disconnect. And so the lack of connection can worsen stress and mental health symptoms, increasing the risk of a psychiatric crisis. And body regulation, when someone can't calm the physical stress, when it's teetering on the other side because of the physical stress, their body starts to compensate. It's trying to figure itself out to regulate itself. And so there's increased heart rate, increased anxiety, increased stress, and possible panic attacks because our body is telling us, I don't feel safe. And they can become overwhelmed and lose control. And this also increases the risk of a psychiatric crisis. Emotional regulation. It's an intense feelings that build without relief. This is where we have those impulsive behaviors, those mood swings, even withdrawal. And this increases the psychiatric crisis like self-harm or even a breakdown. And executive functioning, poor impulse control, struggles to manage stress while making safe decisions. Again, can be impulsive, even skipping treatment or a failure to seek help at all. So, for example, they might act impulsively during a crisis, which can lead to worsening symptoms or a psychiatric emergency. So, from a learning leader lens, which we are all in this class today, learning leaders, we focus on these four key areas as the foundation for training our staff and our clinicians. And again, this is the same framework that guides our culture in our milieu spaces on how we care for our people as well as the children we're serving.
We have a few questions about this, if you all wanted to take a second to answer. One, someone was asking, how do we help people, or how do we help young people overcome learned helplessness, which I know you all just talked about, when the conditions and or relationships aren't able to be changed?
So the way that I like to do this from a clinical standpoint with my clients is to try to break things down into very digestible segments. Because usually what happens when we get into a pattern of learned helplessness is we start talking big picture. And what I mean by that is, well, nothing's ever going to change, right? And everything's terrible. But like, what if we thought about like what could we do? Like, what could we do in the next 30 minutes to help regain some of our courage, to regain some of our confidence? And so that's my favorite intervention for that, right, is trying to like look at smaller scale. I think large scale when it comes to those feelings is like a really good way to avoid what's in front of us, right? It kind of becomes our defensive shield is to linking everything back to in the big picture, nothing will get better, right? And so sometimes it looks like taking very small steps. Once I had a client that I was like, what if you just disagreed with somebody, right? Because like very similar to what the question was, struggling, there wasn't a lot of environmental or relational things that could improve. And so what if I said, what if you just like didn't agree with something? What if you said, oh, I don't really see it that way? And then you didn't say anything else, right? Just little ways to express yourself to get some of that validation, instead of just kind of becoming a doormat to those adverse circumstances. So I don't know if that's a good answer. That's my favorite way to try to help get someone to see like smaller scale, right? And not just default to the shield of the big picture.
Thank you. There's a couple comments in the chat as well about building resiliency in girls with ADHD, since they have a propensity for RSD as one of their main symptoms. And then someone also asked about building self-efficacy in people with low and or very low IQ. And someone dropped an article in there too, but I wanted to bring those to your attention as well.
So when we say RSD, are we talking about like risk behaviors?
I think that they might be referring to rejection sensitivity.
Rejective
Dysphoria, yeah, but
sensitivity.
they can correct me if I'm incorrect.
Yeah. So that I think again, I would encourage them to, and I know I may be telling you something you've already done, right? Which is like stepping back and really analyzing that behavior. One of my favorite things to say to clients is you would be surprised at how little some people think things versus other people, right? So when it comes to rejection, looking at, if they were rejecting you, you feel like they were, but how would you know if they were accepting you, right? And so sometimes flipping the script a little bit, because sometimes they don't know. They only know what they feel like looks like rejection, right? Or not being included. I think, the same thing with like individuals with intellectual disabilities. That's another population that has a lot of rejection sensitivity that gets really learned helplessness and stuck. Sometimes because you get more good feelings from being helpless and having someone help you than doing things independently. And so I think it's really important to make sure that you're getting a lot of good validation and support when you're functioning independently, because we do see clients like that reject, or I not reject, but just like regress back to a stage where they're not functioning with their full skill set because it feels good to be cared for. And so, if you're seeing that, trying to look at like, what are they seeking that they may not be getting? And so, with your teen girl that might be experiencing rejection sensitivity, are they getting enough acceptance? What would it look like if somebody was accepting them? Is there someone in their life that they really want to be, opened in and accepted by? And I'm trying to read this other question.
Yeah. Essentially, are you
Oh.
looking at Jessica Tipo's question, Bethany?
About the
Yeah.
bullying. Okay. Go
Yeah.
ahead.
It looks like essentially what she's describing is that the kind of the community belief in the community that she's discussing is saying that like it's almost a child with ADHD is maybe being bullied because they need to toughen up or they don't have enough resilience. And so the concept of like resilience is being put on like the victim needs to grow in that way, as instead of like we need to maybe manage the victimization or like those more, which also we've talked about stems from the resilience, but some of those more bullying behaviors. So I think that that's kind of an interesting, I think that that's kind of safe place for adults to go when they don't know how to respond to something like this.
Yeah, I mean, absolutely. I think that's what resilience isn't, right? Well, they need to toughen up. Well, there's certain things that are like inalienable, which is that it's not acceptable to say mean things to people. We are not tasked with teaching people to toughen up. That's not what we do. No one is actually in charge of that. Like that's a self-appointed role. That's, like you said, a masquerade for being harmful and unkind. And so I think the point is like, regardless of whether or not they're being sensitive or, maybe overreacting, they're feeling something that doesn't feel good. And if the intent of whatever it was that made them feel that way wasn't to cause that, then it needs to be reevaluated. But I would agree, like often people use resilience as a shield to be mean or say things that aren't actually helpful. And so I don't necessarily have a good solution for you, but I definitely see you and I hear you because this is a problem, right? And this goes back to that people don't really understand that resilience isn't about bouncing back or being tough.
Okay, I think that's our current questions, Bethany.
Yeah. So I'll hand this back over to Brett.
Yeah, so resilience in practice, what we've learned, and Bethany just shared that first one that it's just not about bouncing back. It is a process, and it's growing through adversity. So what a growth opportunity there for ourselves and for the people that we serve and help. Low resilience is widespread, even without trauma or severe symptoms. Self-efficacy, it fuels resilience, and low self-efficacy drains it. That's that learned helplessness that Bethany shared earlier. And interventions build trust. They promote mastery and strengthen coping to enhance resilience.
Yeah, and I think it's important to remember that interventions take time. This is not a linear process. And I think that's where, we can overwhelm some clients because we want it to hurry up and get better. And that's like not always the case. So when I talk to you about applying a resilience minded approach, this is going to look at looking beyond the symptoms and also assessing a person's strengths, supports, and protective factors. It recognizes that vulnerability and self-efficacy both shape outcomes. And so people are not defined by risk alone. Interventions can be tailored using body-based strategies and strengths-focused work, attachment-informed care, and group support. So the goal is to build beliefs, relationships, and inner resources to support resilience over time. And so, to go back to the chat and what we were talking about with some of our, IDD clients, if it's being reinforced to them that regressing and having some of those learned helpless skills is the best way to get the good feels and to feel cared for, we have to flip the script and help them feel cared for in all these areas, right? Because regardless of the intent, they're feeling a feeling, right? And we need to analyze that. So applying resilience-minded approach looks like analyzing why you might have a teenager that's engaging in risky behavior or putting themselves at risk and maybe not thinking, oh, they're defiant, we need to punish them, but maybe looking at their interpersonal safety. Do they have good interpersonal safety? This can look like, task avoidance and things like that. Like at the heart of that, are they capable of accomplishing the task? If they are, what's the barrier? Being aware of these things and looking at that from a lens of being able to tailor your intervention, focusing on the body. A lot of people, when I talk to people about these 4 domains of resilience, people don't have very good bodily awareness. When you have a headache or you're constipated or you're dehydrated, Those are body-based things. Those are executive functioning things, right? Those are your, awareness of your body, where it is in your environment, how all of your systems are communicating. And so it's really important to look at this from a holistic perspective. And at the end of the day, and if we teach these skills, we also have to help the person have good beliefs about themselves. So it doesn't matter the level of intervention we provide if they don't believe that things can get better, or if they cannot see beyond the things keeping them stuck. And that's a very fine line to walk. You can't we all, I'm sure, anybody that's worked in a clinical capacity has had a client that you could not unconditionally positive regard into feeling better. You can't always challenge their reality. You have to look at the evidence that's made them feel that way. And a resilience-minded approach is looking at the evidence that has led to the way the person is feeling, seeing things, and understanding what it's going to take for the evidence to change. But before we can do anything, we have to understand how we got here. And so when we talk about violence, right, and permitting violence, which is a huge thing that we deal with when it comes to supporting youth, we have to look at like the proactive things, right? So the mental health screenings and treatment, reporting systems, not being afraid to communicate what's going on, or when you notice something and you may be having a heightened sensitivity and it may turn out to not be a big deal. Inclusivity, so involving students, community partnerships, working to practice what you preach, so promoting good citizenship and character, making sure we feel safe while we express our emotions. Often, if anybody's ever been a parent, kids are like, well, I didn't tell you because I didn't want you to be mad. Or, we've probably all had a situation where a child didn't tell somebody how they felt because they didn't want to upset them. And so it's important to know, like, help reaffirm to kids and, our clients in general that they have a right to their feelings and they can express them in a healthy manner, and we're not going to be mad at them. I don't know why that is like the knee-jerk reaction. I think it's often because we go into problem-solving mode, and so in that way, it may seem like we're trying to fix their feelings. We all know, good school engagement that promotes constructive activities and allows for supervision is always a good prevention to violence, and supporting resilience, conflict resolution, and peer mediation. I don't think that we as a society do enough of like the restructuring and the recovering from conflict. So we stop the conflict, but we don't ever do the part where we talk about it and how it may have made us feel. And that's because it's not comfortable. So good peer mediation, giving kids opportunities to have healthy experiences with adults, strengthening economic supports. So looking at the things that are making us more vulnerable and more sensitive. Strengthening skills, right? So looking at the skills we already have, because remember, it's not a behavior problem. It's just an area where we need more skills, and again, restorative practices. All of these things help preserve resilience and prevent violence in the school setting and in the community setting.
I'd say, Bethany, that was a Zoom mic drop on that in your last slide. So
Yeah,
thank you for being so inspirational. So building resilience, it is possible. Resilience is dynamic; it's not fixed, and barriers can be transformed into opportunities for growth. And as I shared earlier, an opportunity to grow. I mean, that is it's a journey, it's a process. It's not just bouncing back from adversity and a challenge or change. It's actually allowing ourselves to be stretched and grow, and inspiring the people that we serve and take care of, that they too can embrace that growth opportunity in the midst of their challenges, adversity, and traumas. And then by fostering connection, safety, and opportunity, we help people not only survive but adversity, but actually thrive because of it. And so we all need healthy coping mechanisms. I love, Bethany, you shared about the importance of just peer intervention, peer support. I know from my past life that's been critical as a firefighter through a fire chief to have peer support to validate and empathize the challenges and struggles of the roles. Just to have someone to listen to. That's why I love therapists, by the way. Um, but especially in hard times. So we all need healthy coping mechanisms. And when we see some symptomatic responses in folks, like we need to dive in and go be that peer person and say, hey, like what's going on? And what can I do for you? Because I see these symptoms. And so regardless of background, economic status, family makeup, the developing brain needs three key factors for healthy development: exposure to caring and consistent adults. We know that that's one reason, whether we're in healthcare, mental health care, where we touch and pour into people's lives, that providing that stability and that consistency for kids, for youth is so critical. Exposure to enriching opportunities and activities and freedom from toxins, both chemical and stress. So may we as helpers not just lean on resilience, but lean into resilience as we serve the work of fostering connection through relationships, environment, and support. See, caring for people and connecting with people is our mission, and resilience is just one of the major bridges to thrive with our people and for our people.
Thank you, everybody. Thank you, Brett, for that. Don't keep complimenting me and I might float away, So we all need those good feels, right? So we really appreciate everybody taking the time to listen and talk with us today. And so now we're open for questions.
Yeah, there was one in the chat about any recommendations for further reading or education on follow-up conflict, some of the restructuring that you mentioned.
Yeah, absolutely. If you put your email in the chat, I could share something with you that I don't know what setting you work in, but this is something that I implemented specifically in our residential psychiatric units at Camber that has been pretty successful. Just because in our setting, often consequences of behavior are pretty much at the group level, right? And so, when kids are having a hard time bouncing back or, getting, working together as a team in like the therapeutic space, that can be a hard thing. And so I started like a town hall meeting that's led by a clinician, and I can share some of those questions. If you put your email in the chat, Brittany can get that to me and I can share.
I think at this point, Bethany, we might just have to send it out to everybody.
Okay.
They're all dropping their email.
That is fine. That is fine.
But yes, I can make sure that they get that.
Yeah, that is absolutely fine.
Not seeing any other questions. Someone asked for trainings for psychologists who pledged to work with kids. Oh gosh, it went away. I lost that question. Okay, well, goodness. Sorry, everyone. That question just disappeared on me. Information on working with parents is in there. Lots of good questions. Oh, here we go. Psychologists in our area who have pledged work with kids in our county to help build these skills, possible trainings for psychologists. That's what she was looking for. So, yeah. So I don't know if you know of anything.
I don't know of anything off the top of my head. If they put a request through our HubSpot, we may be able to do something more tailored to their need. But I unfortunately don't know anything at the top of my head.
So I'll have Bethany share with me that information on the restructuring, and I can add that to one of the emails that goes out to everyone. So we all have your email addresses, and so I'll make sure that gets to everybody. Yes, so the CEU will come after the completion of the survey. That email should go out about 10 minutes after we end this session. You do not have to complete the survey immediately. No. You can complete it later. Make sure that when you're completing the survey, you type in your email correctly, because they will bounce back and it won't get to you. So double check that when you're filling out the survey. Okay. The survey link will not be in the chat, but when we end this webinar, it should pop up. You'll also get an email with a link to the survey. And then I'm going to put an email address in the chat, virtualevents@risecounselingkc.com. Please email me if you don't get it. Yes, you will get the CEU certificate as soon as you complete the survey. It's an automatic process. Okay, it's officially 1:29. Not seeing any other questions. So I'm going to stop the recording.
Thanks, everyone.